CRUK Cambridge Centre podcast. In this Integrated Cancer Medicine Research in Focus series, I talk to various ICM members about their research and how it is supported by the vision of the Mark Foundation Institute for Integrated Cancer Medicine. MFICM research uses cutting-edge analytics to maximise the use of diverse high-volume datasets and by capturing cancer heterogeneity in time and space in patients receiving active treatment. Integrated cancer medicine aims to transform the way the world treats cancer by affecting patients along their treatment pathway and ultimately accelerate cures. Today I have with me Marika, Reinius and Maria Delgado Ortet to talk about 3D mould-guided radiogenomics in ovarian cancer. Marika is a clinical research fellow at the CRUK Cambridge Centre at the University of Cambridge, and Maria is a PhD student in the Department of Radiology and the Department of Engineering at the University of Cambridge. So thank you very much for joining me today, ladies. To start with, can you tell us what radiogenomics means? That's a nice broad question to start us off. Maria, let me come to you for that one.
Yeah, sure. Simply put, radiogenomic studies explore the relationship between radiomics and genomics. And so now let's break it down. Radiomics involves extracting and analyzing quantitative data from radiological images like CT, MRI, or PET scans, revealing hidden insights beyond what the naked eye can see. And on the other hand, genomics deals with data derived from tumor tissue obtained through invasive tumor sampling. So now where it gets really interesting is when we combine these two worlds. By integrating radiomics with clinical and molecular data, researchers have discovered that this fusion improves the accuracy of survival prediction compared to using each modality alone. However, achieving this synergy requires precise spatial alignment between radiological imaging and histopathological tissue samples. And that's why we propose the use of 3D printed molds.
That's a fantastic definition there. Thank you very much for that. So my next question then to Marika is, can you outline what the 3D tumour mould technique involves and what do we use it for?
Absolutely, and thank you so much for having us. So the 3D mould approach is a research technique that was designed to preserve the spatial information about the original orientation and location of tumours and to allow tumour samples that are taken for analysis to be traced back to the precise spatial coordinates that they came from within the patient. And this is useful because ordinarily at the point of a pelvic tumour being surgically removed from a patient to be examined by a pathologist, information about the exact original location and orientation of where it used to lie within the patient is lost. Now, in clinical practice, this is not an issue at all because it's not information that is relevant for standard diagnostic purposes. But what this means for radiogenomics research is that if you wanted to trace routine tumour samples back to their original coordinates on preoperative radiological scans in a retrospective way, that's actually really difficult to do accurately. And so the 3D mould technique allows us to achieve this through a multi-step process. So it involves, firstly, radiologists annotating or drawing around the contours of tumours on radiological images such as CT or MRI scans in a procedure called segmentation. And these segmentations allow computational scientists like Maria to model the size and shape of the annotated tumours in 3D. And we can then use these models to 3D custom print molds for individual patients' tumours. And what is really fantastic about these molds is that the original spatial coordinates of the corresponding tumour are embedded within the mold. And so when the tumour specimens are sliced and sampled by a pathologist using the 3D mold as a guide, the original spatial coordinates of each sample can be traced back. So the idea here is that this will allow us to sample tumours in a more systematic and precise way in order to study the spatial relationship between radiological imaging and tumour tissue features in detail and to really test the overarching radiogenomics hypothesis, which is that medical imaging data reflects underlying biology.
Wow, what a fantastic definition. Thank you so much. So what challenges does ovarian cancer present in terms of diagnosis and treatment? And why is the 3D mould approach useful for this type of cancer specifically? Marika, will you tell us that one?
Absolutely. Thank you, Ellie. So there are many types of ovarian cancer, but I'll focus on high-grade serous carcinoma, which is a subtype that we are particularly interested in. And the reason is that it is the most common and most lethal form of ovarian cancer, and it is a disease where patient outcomes have been incredibly difficult to improve over several decades. And one important factor that makes these tumors so challenging to treat is that the genomes, or the genetic makeup of these cancers, are incredibly unstable, which leads to very high levels of molecular and cellular complexity and heterogeneity. And what we find really interesting is that radiological features of this disease are also highly heterogeneous. And it has been shown that higher degrees of imaging heterogeneity correlate with poor patient outcomes. And as Maria mentioned, there have been several ovarian studies and in other tumors in recent years to indicate that medical imaging features could become important tools in predicting patient outcomes or response to treatment, either alone or ideally in combination with other data types such as clinical and molecular data. But importantly, most radiogenomic studies to date typically analyze a single tumor sample per patient, which may not actually be entirely representative of the overall biological behavior of the whole tumor. And so in order to move one step closer to being able to understand these imaging features and to use them to predict patient outcome, we really want to have a detailed understanding of what these imaging features might, in quotes, mean, or what they might be able to tell us about the underlying biology of these tumors. And given how heterogeneous ovarian cancers are, it is particularly important to be able to study these tumors in detail and for such complex multi-level data to be linked spatially using approaches like the 3D mould technique.
And just for our listeners and for me, can you tell me what heterogeneous means?
So it means that if you were to take samples from different parts of a tumor, they might be very different. And this is to do with how complex this tumor is, that it can evolve and change over time.
Yeah, thank you. That's great. And so how did you begin developing this technique? I mean, it sounds so complex and so amazing. So what was the thought process and how did it begin to come into development? Maria, do you want to take that one?
Yeah, sure. As Marika briefly mentioned, previous reports have highlighted the success of utilizing 3D printed molds for radiogenomic studies in various cancer types, including prostate, hepatic, or renal cancers. And there was also a publication about a case report in ovarian cancer. Notably, the latter case report of a single patient with ovarian cancer was led by Professor Evie Sala during her time at Memorial Sloan Kettering, New York, and she was also one of the leaders of the work we're sharing with you today. Our team here in Cambridge took inspiration from these findings and started by modeling 3D molds specifically tailored for kidney cancer. In particular, Dr. Mireia Crispin Ortuzar, a pivotal member of our team, published a pilot study in renal cancer in 2020. This study involved 6 patients and provided valuable insights into the application of 3D printed molds for renal cancer. However, what sets our work apart is our focus on the diverse characteristics of ovarian cancers commonly encountered in clinical practice, as Marika wonderfully explained before. So no previous study has delved into this variety comprehensively. And our work presents the first prospective pilot study at Addenbrooke's that serves as the proving ground for these innovations.
Wow, that's really exciting. And what further technical developments did you implement in your study in particular?
So in our study, we introduced several technical advancements to address the gap in research, focusing on the diverse characteristics of ovarian lesions. Our approach involved a meticulous exploration of the iterative pipeline development. One of the key highlights of our study is the remarkable tunability of our mold design. This innovation not only improves the precision of our methodology, but also contributes to the adaptability needed for studying a wide range of ovarian lesions. Additionally, we proposed a novel automated tumor rotation algorithm. And taking a step further, we implemented the printing of the 3D replicas of the tumors. This not only aids in visualizing their lesions more accurately, but it also proved to be very useful to correctly orientate the tumor within the mold. Finally, we also made special effort in ensuring the stability and orientation of the tissue slices within and outside of the mold. When the lesion is inside the mold, we make sure that the height and the design of the wall is robust, And when it is outside, we incorporate an innovative inbuilt orientation slit to maintain slice orientation consistently. This may now sound a bit too abstract, but please do refer to the paper for a more detailed visualization.
Yeah, thank you. I'll put a link to the paper in the blurb underneath the podcast so people can see it. And I presume it's graphically portrayed in the paper as well, is it?
Exactly, yeah.
Perfect. So does this require specific equipment? And how would you envisage the 3D mould approach working in settings outside of Cambridge?
Addressing the question of specific equipment, I think is where the beauty of our 3D printed mold technique lies. It is so simple. The sole equipment requirement beyond the computer is a 3D printer, which happens to be both affordable and easily accessible. Like we know many people have 3D printers at home right now. And to facilitate widespread adoption, we've taken extra steps to make our pathway accessible. In our published paper, we've provided clear and detailed explanations of the entire process. And moreover, recognizing the importance of collaboration and knowledge sharing, we've made our code open source and it underwent thoroughly testing for reproducibility. This means that any institution interested in implementing our technique can readily access and understand the code, fostering a collaborative environment where advancements can be shared and adopted across various settings. So in essence, we've designed our approach to be inclusive, ensuring that the benefits of our work extend far beyond the walls of Cambridge.
Am I right in saying that you are both from different disciplines and different departments within the university? So how did you come together as a team? How did that matchmaking process work? Marika, do you want to take that one?
Absolutely. So this really has been a truly multidisciplinary effort, and it's been an absolute pleasure to be part of. So as you say, lots of different departments involved. To begin this journey, we were brought together by Professor James Brenton and Dr. Maria Crispin-Ortezar, who co-lead the ovarian program at the Cancer Research UK Cambridge Centre, and by the efforts of the Cambridge Ovarian Radiogenomics Group, previously led by Professor Avesala and subsequently by Dr. Lorena Escudero. And from there, we were able to bring together an amazing team from a wide range of disciplines at Addenbrooke's Hospital and within the wider ovarian research effort on campus. So starting with a pre-op mould preparation stage, this was made possible by the OVO4 research study team and the ovarian radiologists, the computational scientists from the departments of radiology and oncology, and with a particular thanks to our colleague and friend, Dr. Cathal McCaig, for coordinating the radiology side, as well as getting properly stuck in with Maria and myself on the 3D printing and troubleshooting. And then on the day of each surgical procedure, the Addenbrooke's gynecological oncology surgeons and their operating theatre staff were instrumental in retrieving and placing the resected tumour specimens in their moulds. And from there, we transferred the tumours in their moulds for processing at the Human Research Tissue Bank team. And we especially want to thank the ovarian program pathologist, Dr. Mercedes Jimenez-Linan, who has been hugely important not only for the tissue sampling aspect, but for her expertise and support for the overall development of the project. And then finally, at the stage of analysis of the tumour samples, we've been working very closely with colleagues at the Cancer Research UK Cambridge Institute, particularly the Compliance and Biobanking team and the Histopathology, Genomics and Bioinformatics core facility teams. So it really has been an immersive and exciting team effort where each prospective case involved up to around 20 team members. And we're hugely grateful for the critical input of every single person. And overall, I think we were brought together by the strong ovarian research effort here in Cambridge, but also by the really creative and ambitious nature of this project. And I think we all learned something new, and it was certainly the first time I did any 3D printing.
Wow, that is just amazing that all those people contributed to this, and it really highlights what a wonderful hotbed of research Cambridge is. And you can get access to, clinical samples, and it's just bringing everybody together. It is just fantastic to hear about this collaboration.
Absolutely.
So what are the challenges and opportunities within this type of multidisciplinary research? I mean, imagining all of those people, there must have been times when, things slipped or it was a bit difficult to get hold of the right person at the right time. So tell me a bit about that.
Yes, thank you. So I think that I speak for everyone on the team when I say that the opportunities overall of our highly multidisciplinary setup greatly outweighed the potential challenges. The main challenge when we first started was how to pull off a fairly operationally complex prospective research pathway involving such a large number of teams and complex interdependent tasks, all within a clinically defined short timeline between imaging and surgery in a busy tertiary centre clinical setting in the NHS. But actually, we were continually guided by our number one priority as a team, which was for the research pathway to always fit around the standard clinical treatment pathway without in any way impacting on clinical timelines or workloads. And because of that, it was possible to coordinate our research effort efficiently by anchoring our research tasks around each patient's treatment timeline. And so the busyness of the clinical setting was actually, in fact, an opportunity for us to come together really closely as a research team. And the biggest opportunity has been the very fact that we were able to conduct this research in the Cambridge campus. I think it really is a dynamic research environment which simultaneously manages to be really wide-ranging in expertise, but also close-knit in terms of team working. So, for instance, the case selection and planning at the start of each case involved rapid discussions between ourselves, radiologists, surgeons, pathologists, and the computational team to rapidly agree goals and timelines. And then during each case, there was a lot of troubleshooting to do, including with a printer, under a lot of time pressure. But through really close communication between Maria and myself and the radiologists, we were able to come up with ideas really quickly and implement them rapidly. And the ovarian radiogenomics group also provided a multidisciplinary environment in which we could discuss our learning after each case and to improve the pipeline iteratively. And this really was key in designing a clinically relevant research pathway and computational pipeline. Our collaboration with the Human Research Tissue Bank and the Cancer Research UK core facilities has also allowed for a really seamless transition to the laboratory processing and tissue analysis stage. So yeah, all in all, this project has benefited hugely, I think, from the perspectives and expertise of so many different disciplines represented within our research team.
It's a fantastic success story, isn't it? Really, it's just wonderful to hear how people have come together. I mean, where there is a will, there is a way. I feel that is portrayed in this project beautifully.
Certainly. Thank you.
So, Marika, tell us what are the next steps of this research? Where are you going with it from now onwards?
So I would say that our next steps are broadly twofold. So firstly, what we really want for this 3D mold technique is to ensure that it can continue to be improved and that it can be implemented more widely in the ovarian research community. So as Maria said earlier, we have shared our initial process of iterative pipeline development in a lot of detail in our pilot paper and also made the associated code fully available. And we've also been collaborating with groups in the USA and Italy with a particular pleasure of advising them on setting up their respective 3D mold research pathways. So definitely watch this space for 3D mold based insights, hopefully in the next years to come. And secondly, what I'm currently working on as part of my clinical PhD research is to focus on detailed 3D mold-based molecular profiling and computational pathology image analysis. Few studies have addressed adaptation and clonal selection during neoadjuvant chemotherapy or chemotherapy that we give before surgery in high-grade serous carcinoma and the heterogeneity of the disease, which has made this so difficult to study. So when setting up the research pathway, I particularly wanted to utilize the mold approach to comprehensively study the impact of neoadjuvant chemotherapy on pelvic tumors in 3D. So to do this, I've designed a detailed spatial transcriptomic study, which basically maps gene expression across subregions of residual tumor cells across bilateral or the right and left ovarian masses from one patient, which were resected following neoadjuvant chemotherapy and comprehensively sliced at 5mm intervals using 3D molds. And I'll be combining this data with data extracted from digitized histopathology images, which capture the entire tumor cross-section of each 5mm thickness tumor slice. And the idea here is that this will allow me to start mapping out subregions that display different degrees of response to treatment within and between the right and left ovarian masses, and to understand the mechanisms that drive the tumor cells that actually manage to somehow survive chemotherapy. And I'm also really interested in understanding how the biological behavior of what we call the tumor microenvironment, or the cells and the structures that make up the environment that tumor cells exist in, might differ between areas of differential response. And we want to be able to then map these features back to the imaging features of the CT and MRI scans performed prior to surgery, and to understand the relationship between the radiological and biological features. And so it's been fantastic to welcome Hannah Clayton, who is a brilliant PhD student in the Crispin group, who has joined the 3D mould team to help us co-register the tissue slices with the radiology and to extract the radiomic features. So our joint focus is now on realizing the vision of using the 3D mould approach to start reconstructing co-registered radiological and biological features in 3D. So we're really excited to be doing this work, and hopefully we'll be able to share some insights with you in due course.
That's really exciting. And I think just to take a step back from this, just so that the listeners understand, one of the key problems of treating ovarian cancer is that it's a metastatic disease. So there are different lesions in different places, and not all of them respond in the same way to the treatments. I mean, that is one of the fundamental challenges with this type of disease, isn't it?
Absolutely, yes. So it's really important for us to profile the different tumours across the abdomen and pelvis to try to understand how they differ, both in terms of the imaging and the biology. And another next step would be for us to start understanding how we can co-register metastatic lesions in ovarian cancer as well. Our current pipeline mainly focuses on pelvic disease.
Yeah, that's really interesting. So do you think that the 3D mould approach could be incorporated into an integrated cancer medicine approach? And what impact do you think this could have on patient treatment outcomes in the future?
As we've talked about, the 3D mould approach uses cutting-edge technology to make use of high-dimensional, what we call high-dimensional multimodal data. It's a very complex data to capture tumor heterogeneity in time and space. So almost word for word, I think, this really strongly aligns with the integrated cancer medicine approach.
Yes, I'm just thinking that could have come straight off my website. You're absolutely in the right area. Yeah, totally agree.
At the moment, it is very much a research technique in development, and the main challenge is that it's still rather labor intensive. So a lot more work will be needed if we were to make this a standard clinical procedure. But we've shown with our pilot study that it is absolutely possible to deliver it within clinically determined timelines. And so it definitely has the potential to be implemented within clinical trials in the first instance. And in that setting, I think the mould approach could serve as a really valuable research tool to allow the impact of novel treatment approaches on tumours to be studied in fantastic detail in 3 dimensions, which would allow the learning from really precious clinical trial samples to be really maximised. And in terms of the standard diagnostic pathway, it's not possible or affordable to comprehensively study all of the patient's tumour using molecular profiling technologies. And so going back to the intended aim of the 3D mould approach in shedding light on the relationship between radiological and tissue features, one way that the 3D mould-based insights might have an impact is by helping us to refine methods for selecting prognostically important and biologically distinct subregions within tumours that we should be targeting for sampling and molecular analysis. Ultimately, we discussed that outcomes in high-grade serous carcinoma have been incredibly difficult to improve despite decades of research, at least in part owing to these high levels of what we call tumor heterogeneity. And I think what we are learning is that to be able to change outcomes for patients, particularly with ovarian cancer, we really need to start stepping back and changing the way we think about and use the data that we already collect routinely as part of standard treatment. So radiology and histology images are extremely rich in information. We're learning that they can provide prognostic and predictive information. So we really need to start thinking about tumours in 3D, and I hope that our work will contribute to an understanding of how we might start combining the multiple data types in a spatially orientated way. And most importantly, to convince ourselves as clinicians and patients of the clinical utility and acceptability of complex mathematical features extracted from available medical imaging. I think that the features need to be biologically explainable, and this is what we hope the 3D mould technique will contribute to.
It's such an exciting prospect, so it's brilliant to hear you talk about it so passionately. My last question to both of you really is, where do you see your research taking you in the next 5 to 10 years? Maria, do you want to take that one first?
Yeah, sure. So now that I'm finishing my PhD, everything feels a bit uncertain. Like suddenly you are, like you can choose whatever you want and see what you want to explore. I really enjoyed my time in ovarian cancer research, and especially in cancer heterogeneity. I think it's an important clinical challenge. And it's something I really want to continue doing. And from working in this project, which was so multidisciplinary, and I was just coming from the computational side, and within that side, especially really focused on imaging, I learned that genomics play an important role. And I don't know as much as I want of it. So really for the next few years, I really want to focus more on genomics and the bioinformatics behind genomics and see how I can keep contributing to cancer research and heterogeneity understanding.
It's amazing to have a brilliant brain from the computer department fully involved with healthcare and cancer research. It's just such a success story. Thank you, Maria. And Marika, where do you see your research taking you in the next 5 to 10 years?
In the next year, I'll be completing my overall PhD work, which aims to characterize the genomic, tumor microenvironment, and radiological determinants of first-line treatment response to high-grade serous carcinoma. And to do this, I'm combining insights from this 3D mould study with multi-site radiomic, pathomic, and genomic data from the highly annotated NEOV cohort, as well as genomic and what we call imaging mass cytometry data from the completed ICON-7 trial. And in terms of future research in the next 5 years, we're currently preparing translational work associated with the large ICON-8 and ICON-8B randomized control trials. And the methods and results from my PhD will hopefully play a part in informing the analyses that we undertake in these cohorts. And so I look forward to continuing to contribute to this large team effort, which will further explore multimodal predictors of treatment response in ovarian cancer. And we know that achieving a good response to treatment in the first-line setting is really critical. So I hope that in 10 years, we will have drawn on collective insights from 3D mould, the ICON trials, and other ongoing ovarian studies to start implementing innovative translational work as part of clinical trials of novel neoadjuvant treatment approaches. And from a personal point of view, in the next few years, I'll be completing the rest of my specialist training and starting out, hopefully, my early career as a medical oncologist. And longer term, it really is my dream to be able to witness outcomes for patients with ovarian cancer improve significantly within the time of my career. It would mean a lot if it was possible to play a small part in contributing to this. I'm really grateful for the opportunity to learn and experience translational research as part of my current clinical research training fellowship, which has really confirmed my wish to incorporate significant research components in my future career. Yes, to this end, I hope to continue my academic research following my PhD. There are so many people I want to thank, but I know it's not possible to list everyone. But I think on behalf of the team, if it was possible to give a huge thank you to patients living with ovarian cancer who so generously participate in our research, this means a huge amount. So thank you. Also, thank you to my primary supervisor, Professor James Brenton, and my former and current co-supervisors, Professor Eva Sala and Dr. Mira Crispin-Ortesar, respectively, for their guidance and mentorship and for this fantastic training opportunity. And lastly, if it's okay, I would love to thank the Cancer Research UK Cambridge Centre for very kindly funding this research.
Thank you both so much for this brilliant conversation today. It's so exciting to hear early career researchers as yourselves so enthusiastic about your research and so much hope for the future of translating the research to treatment outcomes and, you know, obviously involving cancer patients, our wonderful ovarian PPI group. It's just so fabulous to have them involved in so much of what you do. So thank you, ladies.
Thank you so much for your time.
Thank you for inviting us.
If you want to find out more about the work of the Mark Foundation Institute for Integrated Cancer Medicine, please visit our website at www.integratedcancermedicine.org, where you can find details of the ICM vision, all the current research, clinical trials, resources, publications, and team information. You can keep up to date with our latest news and events, and you can also sign up for our newsletter. If you would like more information about the work of the CRUK Cambridge Centre, please go to www.crukcambridgecentre.org.uk, or you can connect with us on Twitter using our handle @CRUK Cam Centre. Thanks for listening, and do join us again soon.